So I will now, you guys have been very well behaved speakers, being right on time. So thank you very much for that, because I know everybody's going to be ready to have a break and get to lunch. But next, we will be having our panel discussion to address questions from the audience. So let me pull up the lovely pictures of the panel I have prepared for you guys. So there are lovely smiling faces again. So I first wanted to start off with a question to the group. We're going to do a poll of the audience. So we're going to go back to talking a little bit about fatty liver disease again. So this is actually inspired by a patient that I saw, and I'm going to start off by saying that there is no right answer to this question. This is just getting an idea from the group, kind of how you're thinking about handling these kind of patients. So this is a 29-year-old that I met, a BMI of 40, type 2 diabetes, for elevated liver tests. Workup showed a fatty liver. We did a fiber scan, which is a non-invasive test to assess for potential stiffness of the liver. And it was concerning. It showed potentially advanced fibrosis or cirrhosis. So she ended up getting a liver biopsy, and it did confirm NASH with stage 3 fibrosis. So in this patient, so poll for the audience, what would you consider next? Would you tell her, do nothing for now? There may be something at some point, who knows when. Dr. Whelan talked about a lot of meds that are hard to say. Refer her to a clinical trial, refer to an intensive weight loss program, or refer to bariatric surgery. So we'll give the audience a little time to put in some answers from that. So this, and of course, anecdotally, this, I'll tell you a little bit about this lady as well. She was also trying to get potentially pregnant as well, which added to some complexities of the case as far as what we might consider. So we won't take that into consideration for the initial answers, but that is something that also made this a little bit more complicated. Because as you guys are potentially aware, if somebody's trying to actively get pregnant, not somebody you want to enroll in a clinical trial. Let me address a couple of the questions I saw coming in earlier from the audience. One was a very good question about, are we doing any of these clinical trials here at the university? And the answer is yes. We were part of, or we're ongoing part of the Regenerate and the Reverse trial, although those aren't actively enrolling since they have all their participants. And we're constantly getting new trials up and going. Things have been a little bit on hold with COVID. We had to hold off in enrolling, but we will be starting that up again. So if you have individuals that you want to consider referring to a trial, this is a place you could send them. All right, so it looks like everybody is thinking about referring her to an intensive weight loss program. And that actually was what we ended up doing for this individual. But again, there's really no right answers, although probably the first one you might have picked up that was kind of my way of saying that it is important to stress that this is something in this young woman that is very concerning, and we want to be very proactive about helping her in her weight loss struggles. So I would agree that the intensive weight loss program is a very good option for her. She'd actually failed a fair amount of those in the past, this particular patient. So we were trying to gauge potentially pursuing bariatric surgery for her, but that was a little bit complicated by her potential pregnancy plan. So that is still an ongoing case I'm trying to address. But for her, a clinical trial wasn't appropriate given her plans for pregnancy, but that is an important thing to consider as well. All right, so sorry, got my thing here. So then looking at another question here, a poll for the group as well. So you've been asked, so this is getting back to Dr. Lane's case. So this is one kind of addressing the issue of when we see these patients and when you're consulted or involved in the care of these individuals. So you're asked to see a patient on the oncology ward who has developed abnormal liver tests. So you can see her numbers there, her ALT up to 350. INR looks okay, Billy's 1.2. So they're receiving immunotherapy for metastatic melanoma. The patient's asymptomatic. What would be your initial recommendations? Would you have them hold on immunotherapy and start corticosteroid therapy? Would you have them get a liver biopsy now? Would you rule out any other causes of abnormal liver tests with further laboratory testing and high quality imaging? Or would you have them continue immunotherapy as abnormal liver imaging of varying severity are common in this class of medication? So we'll let the audience start answering that. And while we're waiting for that to roll in, one question I had for Ashley, I thank you, and thank you again for a wonderful talk. I think those are some really helpful algorithms. I'm glad to hear that that there's been some guidance on what to do with these patients. I know I've struggled in the last few years as these medications are rolling out, and I can hardly pronounce them and never heard of them, and all of a sudden I'm consulted on what to do. Um, so you mentioned that when there's a severe injury that basically you shouldn't be rechallenging. Does that apply across the whole class, or could you consider a different immune checkpoint inhibitor, or if one of them caused this issue, is the whole class off the table?
Depends on which guideline you look at, which makes it really confusing, like you said. But the current guidelines suggest, at least the ASALD guidelines, based on their systematic review, that you could cautiously try to re-challenge, or in patients who received anti-CTLA-4 therapy, you could consider switching to anti-PD-1 or PD-L1 therapy. And there was one study that came out not too long ago that actually looked at in patients who had more severe hepatotoxicity, where oncology really wanted to re-challenge with immunotherapy, starting budesonide. So a steroid that doesn't necessarily have systemic effects actually might be associated with better outcomes. So I guess long story short, some of the guidelines do suggest you could consider re-challenging, but I think everyone needs to take into account that there is a risk they could redevelop pretty significant hepatotoxicity and potentially die. So.
Thank you for that, Ashley. And so here we are getting to our poll of our question.
Good job, everyone.
Yay, go team. You guys were all listening. Good job, guys. I apologize here, Dr. Whelan's struggling with her slides. Thank you so much, Ashley. So I also apologize, I can't see them in my current screen. I can't seem to see if there's any new questions coming in. I know there were a couple others that the group had, and I'll address some of those about fatty liver. But I also had a question for Jay. So Dr. Burton, I think you outlined the benefit of living donor liver transplant quite nicely. One general question, is there any important counseling or a certain population that you would advise are better served with a deceased donor? Are there certain things that you look at where you might say this person really shouldn't consider living donor, that and you should really be more of a deceased donor candidate?
That's a good question. I mean, not everyone can have a living donor liver transplant for a variety of reasons. Obviously, one issue would be if you're very sick or have a lot of portal hypertension. And if you're really sick with a high MELD score, I'd argue, well, you're going to be at the top of the liver transplant list and get a deceased donor. You know, the volume of liver you're receiving with a living donor is going to be at most 60 or 70% with a right lobe. And if you need more because you're sicker, or you know the size of the recipient, that might be an issue. I think a patient who needs a retransplant, that's going to be a complicated operation. A retransplant is a very difficult operation to begin with, so that might be an issue. And then you know, issues with you know, portal vein thrombosis may make doing living donor challenging. Prior surgery, like bariatric surgery. There could be some surgical and anatomical issues that would preclude living donor liver transplantation.
Okay. That helps me. I like having the opportunity to pick your brain, Jay. One other question that comes up for me, and I think it'd be interesting to hear your take for the audience. When I'm counseling a patient on their options, and I can clearly see that they would benefit from transplant. And I'm talking about, the different options, including deceased and living donor. The initial reaction that most patients is, I would never want to put any of my loved ones through that or put them at any risk. How do you handle that when patients say that? How do you balance their appropriate concern for their loved one, but your concern for their risk of dying with lack of access?
Yeah, no, I get that quite a bit. I mean, I try to bring up the option of living donor liver transplant. There's a lot of people that have never heard about it until I bring it up. There's some people that come in knowing that it's an option. It's not for everyone. I mean, obviously a recipient needs to feel comfortable with someone donating to them. If they don't, then we're not going to pursue it and not going to discuss it. I think what I often witness sometimes is a family member who's in the room with the patient who wants to do it, and the recipient who doesn't want them to do it. Um, I think talking to our physician assistant, Lindsay, who donated to her mother, I mean, she was not willing to accept losing her mother, and being without her mother. And so I think, this is something a recipient and a donor need to navigate. And sometimes I feel like I might be offering some counseling to family members in that respect. But I think you have to think about what it's like to be the loved one who wants to donate. I mean, it may be equivalent to running into a burning building to save your loved one. I know if my daughter needed a liver transplant, I wouldn't hesitate to do it. And on the other hand, you do need to protect a donor, from running into a burning building if they're going to, injure themselves. So it can be something that's very challenging, and obviously it ultimately comes down to what the recipient wants to do. But I do think that a recipient needs to understand the perspective from a donor who's willing to do anything to save their loved one. Now, we will, of course, make sure that it is safe for the donor, and the donor is evaluated by a completely different team, an independent social worker. They all see a psychologist. So I think. Of course, my role is for the recipient, and if I think a live donor liver transplant would help the recipient, I do think it's my role to bring that out and bring that to their attention. But obviously, if they don't want to do it, I'm willing to support them in trying to get a deceased donor.
Yeah, no, thank you for that, Jay. Yeah, so that kind of leads into another question that the audience just posed. So if a patient is in need of a transplant, has a family member with similar blood type, what's the process like? Is it like pretty quick right away, or what's the workup look like? What's the time frame?
Well, so if someone wants to donate to their loved one needs to be, have been evaluated and been a candidate for a liver transplant. First of all, you need to have an indication to have a transplant, and you need to be on the transplant list. Once a person has been evaluated and enlisted, and we have felt that they could receive a living donor liver transplant, we've developed an online process where a donor can go online and answer a bunch of questions that are sent to our living donor liver coordinator. And a lot of times, amazingly, people do this the average time people do this is between 10 at night and 2 in the morning. Fill out a questionnaire about their health history, other things that are reviewed by the donor, the coordinator. If they pass that questionnaire in terms of no major medical problems or other things that would preclude it, they are then called by the coordinator where they are offered to get blood testing wherever they live. This would be basic blood testing, confirm their blood type, exclude viral hepatitis and liver enzymes. If that blood testing is then acceptable, they're invited to come to Denver for 2 days of outpatient testing. They all get a CT scan and MRI, which is then combined. A company in Germany does a 3D rendering of this, allows us to create a 3D model to look at all the blood vessels and bile ducts. They meet with a different hepatologist who does a medical health screening. They meet with a surgeon. They meet with a donor advocate, who's a social worker, a psychologist. They have a bunch of blood testing done, EKGs, chest x-ray, to exclude any other diseases. We have found many people who have come forth and have diagnosed people with cancer. We diagnose someone with a cardiomyopathy. We diagnose someone with hemochromatosis. So it's an extensive evaluation of all causes of health and stuff. And then once they're evaluated and approved, we tell the donor, look, you're a candidate. If you want to do this, you can do it. And if you want to do it, do you want to tell the recipient or do you want us to tell the recipient? And then if everyone's in agreement to go forward, we look at the calendar and schedule a date for surgery. You can evaluate a donor very quickly in cases of acute liver failure, and we've done that, and we've been able to do that within about 48 hours. I would say the process that we do with living donor liver transplant is something that usually takes place over several weeks to a month. It's really on the donor's timetable, when they want to be evaluated, what's in their life. This is all driven by the donor. We're not going to force someone to do something that they don't want to do. So it can be done very quickly. It's very easy. I will say, in terms of if there's multiple donors, we kind of evaluate it as they come. We will look over things if we have multiple people at one time and pick which one we think may be the best and start with that one. But we do one at a time. We don't evaluate 10 people simultaneously.
Awesome. We got more questions coming in for you, Jay. So another attendee. So what is the difference between donating right versus left liver? Why would you want to donate right? Because of the risk. So how do we weigh that?
That's a very good question. The only reason you would want to donate right over left is it's purely liver volume and the size of the graft that you need for the recipient. And that really has to depend on the size of the recipient. So, a large man is going to require a right lobe. A small woman could get a left lobe. They could get a right lobe as well, but we would then, if a woman is small, we would say you could get away with a left lobe. It also depends on the anatomy. I mean, some people can't be right lobe donors, some people can't be left lobe donors, but we would always pick the safest operation for a donor. Though sometimes you cannot get enough liver volume by doing a left lateral segment or a left lobe, and you need to do a right lobe.
All right, awesome. So thank you for that, Jay. So just looking back at the other questions that had populated, one thing that came in previously from Dr. Tomaso. So I was really glad to see Dr. Tomaso on the list. He's a veteran of our conference. I know he comes out almost every year from Glenwood Springs. So thank you for coming again this year, even though it had to be virtual. He was asking some about, when we see normal liver tests, does that mean they don't have NASH and you can be reassured? Unfortunately, you can have NASH and even advanced fibrosis with normal liver tests. Sometimes they actually can have their liver tests normalized once they have more advanced fibrosis. So, what I do, my talk today wasn't really addressing some of the workup. I kind of just skipped to knowing what they had, but that's a whole nother challenge, is how do you tackle this massive problem and how do you risk stratify patients? So, what I typically do is, liver tests are one clue, and you can use your non-invasive scoring systems, including the NAFLD fibrosis score and FIB-4. I like to use those in combination, if you have it available, of modalities like FibroScan, which is a non-invasive way with elastography, which is ultrasound technology, quick and non-invasive. That's another way to assess their risk, and then basically risk stratifying patients based on that and making individual decisions on if they need a biopsy to really know. If you're reassured by labs, FibroScan, and their overall risk profile seems low, and you feel like they're low risk for NASH and don't have significant scarring, you can defer biopsy. I typically like to keep them on some kind of monitoring program. What is the right monitoring program is very unclear right now. There's really nothing in the guidelines. So, I typically, it depends on what their risk profile is doing. Are they losing weight? Are they doing the right things? If they are, then, just a FibroScan and monitoring labs, FibroScan potentially 3 to 5 years. Versus if they're getting worse, would you consider a biopsy at some point? So it's very individualized. It's hard to have like a global recommendation. And so it makes it all very challenging. So, all right. So we're getting close to the lunch hour. So I want to thank everyone again. So a few pre-lunch announcements. I guess first, before we finish up our panel, do the panelists have any other burning questions to share with each other, or are you guys getting hungry? And you did an amazing job. So some pre-lunch announcements. So I want to again encourage everyone to explore our virtual exhibit hall. I personally found it a very exciting way to try to interact, have some way of having some more contact with our sponsors and learning more about all these different treatments and managements going on. So we're going to be pushing out the link for that. And so basically what I'm going to be figuring out as well, I'm probably going to pop into some of these virtual booths as well, so maybe I'll run into some of you guys. But if you visit 4 or more of these virtual booths, you will be eligible to win one of 10 $100 digital gift cards. And basically, you're able to enter these booths by clicking on the links on the page. Those will be active, and it'll actually take you to a separate Zoom session, and I believe you'll be able to actually see each other interact. So again, I'm going to pop in and out of some. We'll see if I mess it up or not. I'm known for being technically challenged, but so far so good. So to be eligible to win, you do need to enter your name and email address on the exhibit hall page. And we're not going to share that information with anybody. It's just so that we can make sure we have the right people to draw for the gift card winners. Winners will be announced at the end of the conference, and you should be present to win. But why would you want to leave such an amazing conference? So please return to the webinar. We're going to start session 3 promptly at 12:10 p.m. And we're going to start an exciting session on updates in therapeutic endoscopy. And you'll get to see our next moderator, Dr. Hazem Hamad, share an exciting panel with that as well. So again, I want to just thank our sponsors, as we wouldn't be able to have this free registration and be able to put together this a way to interact and continue education and continue our mission in the virtual world without them. So thank you guys, greatly appreciated. Looking forward to interacting with you guys in some virtual chat rooms.